Hi, I'm Jack Cush. I'm here at EULAR 2022. The meeting just started. A lot of interesting data. Again, a lot still about the oral surveillance study. We covered a lot at ACR 2021, where the study of tofacitinib in lower high dose was compared to TNF inhibitors in high-risk individuals, showing a increased risk of cardiovascular events, of certain malignancies, including lung cancer and lymphoma, and a higher risk of venous thromboembolic events. At this meeting, there are new analyses and sub-analyses that I think try to explain those findings and why they had previously never been seen. Again, I want to remind the audience that there's two issues at hand. One is, was tofacitinib worse than TNF inhibitors? Then you could indict the JAK inhibitors as being the cause of these events? Or was it really that the TNF inhibitors were in fact better at lowering risk than the JAK inhibitors? And that's really not the JAK inhibitor fault, it's just that they weren't as good as the TNF inhibitors they were compared to. I think the second issue in play here was going to be the number of people that actually are affected. These data don't really apply to all of our patients. They were studied in people over 50 who had cardiovascular risk factors, and they were looking for serious adverse events like cardiovascular and cancer. So the data really applies to people over age 65 with a prior MI and a history of smoking. And that was for cardiovascular and cancer risk. Not so much for VTEs, PEs, and DVTs, where that seems to be an inflammation and age-related event. Anyway, at this meeting, what we saw were analyses that showed a few things. First, that you could explain the increase in MACE events and cancer risk just based on the history of, did you have a prior MI, meaning prior coronary artery disease events. Second, did you have a high risk for cardiovascular events that you could calculate, a greater than 20% risk? If both those were positive, now you have a statistically higher risk of MACE and of cancer. But again, it only applies to those two situations, meaning prior MI and high cardiovascular risk. If it was lower, it wasn't so high. If it was MACE, it was clearly higher than if you were on a TNF inhibitor, right? If it was and that you would probably expect. The cancer was probably not different, meaning that if you had, if you were on a TNF inhibitor or a JAK and you had those risk factors, it was going to be an increased risk of cancer events as well. Now, when you try to explain this on the basis of disease activity, everything falls apart. In the analysis that was done and presented, it showed that disease activity, low disease activity, moderate or high disease activity, compared to remission, wasn't any different as far as these risks of MACE and cancer. But, as has been shown before, disease activity clearly increased the risk of, you guessed it, venous thromboembolic events. That was a big risk factor. So we see a few things here. We see that bad things happen as far as MACE and cancer, and why those two are related is really unclear. It may have something to do with they share risk factors and dietary and environmental causes. Maybe that's why they often run together. But they behave differently in these studies than did the venous thromboembolic events. And another abstract at this meeting again confirmed that the risk of having VTEs was having a prior VTE. Also, strangely enough, antidepressant use, obesity, and steroid use, those have been reported in the past. And for some reason, PPIs were protective. So VTEs behave one way, and cancer and MACE events behave another way. And it boils down to three questions. And I get this from my friend John Giles, who sort of summarized this by saying, ask your patients, one, do you have a prior MI? Two, are you at high cardiovascular risk? Three, and have you had a prior PE or DVT? And if the answer to any of those is true, well, then maybe you want to consider something other than a JAK inhibitor. More on this here at EULAR 2022.